Thank you, Padma, for kind introduction. I'll be talking on pediatric uveitis, a challenge. Pediatric uveitis is often a challenge. This is a group of uveitis if they develop vision problem that will be throughout their life. And this is the patients who do not complain of the uveitis. Often it is silent, and it's the parents who has to be careful to observe this uveitis and bring to the patients. Examining of the pediatric uveitis patients is also challenged. Child may not be cooperative. You may need examination and anesthesia. You may coax the patients to cooperate. I have got a chocolate box in my drawer. Even if the patient is below 16, I give a chocolate, and that's how I prepare a rapport with them. So I'll be talking about pediatric uveitis, a challenge. Let me start with the case. I've taken permission for putting you the photograph to show this beautiful child. 8-year-old child, joint pain and swelling in the right knee. As you can see, the swelling is evident. No pain and redness in the eyes, referred by a rheumatologist. And when you looked at the patient's eyes, I found there's already synechia, complicated cataract, and band-shaped keratopathy. It was a juvenile idiopathic arthritis associated uveitis, and juvenile idiopathic arthritis associated uveitis is the most common childhood rheumatic disease, and is the most prevalent systemic disorder in children with uveitis. GA associated uveitis can be pauci-articular, most common, knee joint commonly involved. Chronologically, if uveitis precedes arthritis, then it has got an aggressive course. It can have myriads of complications. Common is that band-shaped keratopathy, chronic anterior uveitis, complicated cataract, glaucoma, vitritis, CME, disc edema, and hypertonic maculopathy, and ultimately phthisis bulbi that can also see. The picture showing a band-shaped keratopathy in a patient of juvenile idiopathic arthritis associated uveitis, and here there is a cystoid macular edema. Juvenile idiopathic arthritis can produce 15% blindness of the affected eyes despite intensive treatment even today. How it presents, the peak incidence of GIO is at the preschool stage, and girls are 3 times more often than the affected than boys. In most cases, uveitis is non-granulomatous, but granulomatous uveitis, broad posterior synechia have also been reported sometimes. The most common extra-articular features of GIA is uveitis. It develops in approximately 11 to 13% of all GIA subtypes, and in all patients with oligoarthritis less than 4 joints involved, the risk incidence increases to 41%. We have to tell that rheumatologists that the children with arthritis should have always an ophthalmic examination. 58% of these eyes had a final vision of 20 by 200, that is a 660 or worse, compared to the 3% who has got just Player's cells. Development of glaucoma, cataract requiring surgery, presence of cystoid macular edema, recurrent episodes of ocular hypertony leading to often blindness due to the phthisis bulbi. Hypotony. Hypotony is more common in GIA than any other form of uveitis because there is a chronic inflammation and damage to the secretory ciliary epithelium. Male gender was found to be an independent risk factor in some study on the development of blindness. The first treatment option is the topical steroids with or without short-acting mydriatics, but the topical steroid you should not use for a very long time. They develop cataract, and you should switch over to the non-steroidal anti-inflammatory agents. Put the patients on methotrexate or biological. 97% of the uveitis specialists are of the opinion that there is an indication for systemic immunosuppressive medication with methotrexate as the first choice. Use of methotrexate in juvenile idiopathic arthritis has been found to be very efficient and tolerable drug in children with GIA. Now biologics have come. 73% of the pediatric uveitis specialists favors additional treatment with TNF-alpha inhibitor, adalimumab or infliximab. Adalimumab is the most preferred choice. And this is an elegant study by Professor Ramanan, adalimumab plus methotrexate for uveitis in juvenile idiopathic arthritis. So what are the surgical procedures sometimes required? This indicates lensectomy, vitrectomy, phaco with IOL is controversial. With the biologics nowadays you can give it, take the chance. But lensectomy and vitrectomy has found to be better visual and long-term prognosis. EDTA chelation for band keratopathy, pediatric keratoplasty when the cornea is very severely damaged, and trabeculectomy in glaucoma. Uveitis and rheumatologists needs to work in collaboration in this type of the uveitis. I wanted to show you another case, a 16-year-old boy, recurrent attack of pain, redness and blurring of vision, history of recurrent fever with systemic hypertension. In the 16-year-old boy, renal biopsy showed acute interstitial nephritis, urinary beta-2 microglobulin was elevated. And this was the kidney biopsy showing acute interstitial nephritis. And this patient had non-granulomatous anti-uveitis both eyes, resolved with topical steroid, oral mycophenolate and prednisolone. This is what tubular interstitial nephritis associated uveitis TINU. Here uveitis specialist and pediatric nephrologist jointly manage the patient. This is an 8-year-old male child, sudden onset of pain, redness and dimness of vision both eyes for 1 week. And this patient have granulomatous anterior uveitis with Busch's nodule. In addition, the patient had arthritis involving interpharyngeal joints and maculopapular dermal rash. And this is a 2-year follow-up after treatment with injection adalimumab and cataract surgery. Patient regained the vision. And this is a case which Sudarshan has talked about it. We published uveitis and sporadic blow syndrome, long-term follow-up on refractory case, treated successfully with adalimumab. Uveitis specialist worked with a dermatologist in this case. Intermediate uveitis in children is another disease which needs to be treated with caution. It's a severe disease with poor prognosis. Band keratopathy mimics GI-associated uveitis, have an aggressive course in comparison to the adults. And they have got snowball exudates as seen in this picture, or snow banking. Highest risk of development of complications. They develop cataract, secondary glaucoma, and even vitreous hemorrhage from the neovascularization of the periphery. Now we need to rule out systemic disease, especially TB and sarcoidosis. Uveitis specialists need to work with internists in this type of cases. Now coming to the infectious uveitis, an infectious cause is responsible to 6 to 33% of all cases of pediatric uveitis. This could be toxoplasma, toxocara, TB, rubella. Congenital toxoplasmic retinochoroiditis we are seeing less and less nowadays. Nothing much you can do in this case. But in case of acquired toxoplasmic retinochoroiditis, intensive treatment with antibacterial like tablet Bactrim DS and application of the prednisolone tablet can reduce the visual morbidity. Toxocariasis should not be overlooked, and this is a posterior pole granuloma, peripheral granuloma, and chronic non-endophthalmitis like picture they can present, and this is a posterior pole granuloma due to toxocariasis. They have got some kind of inflammatory tissues attached to it, and this is a membranes attached to it, and this is a peripheral toxocara granuloma as seen in this picture. Tubercular choroidal granuloma can also be present, and this is a little bit rare. The before treatment of a tubercular choroidal granuloma and after treatment with ADT and steroids. Rubella retinopathy is also another condition. There is no anti-rubella medication. Nothing much you can do. This is patient with a salt and pepper type of fundus. Uveitis specialists need to work with an infectious disease specialist. And this is a case which I wanted to show you multimodal imaging in a case of bilateral frosted bronchitis in a 5-year-old boy secondary to the Epstein-Barr virus infection. This boy had sudden loss of vision in both eyes for 11 days, fever with maculopapular rash over the thigh and buttock. Vision was 3/60 in both eyes. What the patient have is frosted bronchitis. Both eyes are optos images showed characteristic frosted bronchitis. Anti-Epstein virus was very high, 400 to 420 international unit per ml. Anti-rubella was elevated, and patient was treated with the IVMP 250 mg per day for 3 consecutive days, followed by oral prednisolone 20 mg per day, and also antiviral tablet was given, though it's not very specific. And what happened? The vision improved to 6, 5, and 6 in both eyes. Decline in the anti-BB titer to 225 international unit. The fundus shows resolution of retinal vasculitis. Last but not the least, this 8-year-old girl, no pain, redness, white hypopyon, not responding to topical steroid, basophilic cohesive cells with hyperchromatic nuclei and scanty cytoplasm was seen from the AC tap fluid. And it was a retinoblastoma. We need to work with an ocular oncologist in this condition. Ocular relapse of acute lymphatic leukemia, lymphoblastic leukemia can occur. This is a 7-year-old girl who had a complaint of blurring of vision for 2 months. She had undergone chemotherapy 2 years ago for acute lymphoblastic leukemia and was currently on the maintenance therapy. And you can see the convex hypopyon infiltrates in the iris, the bumpy iris surface with infiltrate on the surface of iris. Here also IC tap showed acute lymphoblast. So we refer the child back to the treating oncologist for the bone marrow aspiration and CSF analysis and treatment in the form of chemotherapy and radiotherapy for the management of the relapse. The child was lost to follow-up and later came to know by telephone call that the mother, that the child has unfortunately expired. So what is required is a teamwork in managing pediatric uveitis, which is often a challenge. So rheumatologists, infectious disease specialists, nephrologists, dermatologists come into the picture in managing such patients. But if you need to work properly and if you can put your heart and soul in managing pediatric uveitis, it can be gratifying. This is a drawing made by one of my patients, a child about 13 years who had a VKH, and he is the child who brought this picture of mine in the OPD when he got back the vision. Thank you very much.
Thank you so much for the excellent presentation, sir.
Thank you.
Yes, coming to the systemic steroid use in children, what advice would you like to give it?
I think is that a few weeks is okay, but prolonged use of systemic steroid you all should always try to avoid because there is a chance of growth retardation. So I always put the patients along with the immunosuppressive agents and take up the steroid as soon as possible. Even topical steroids in children, they can develop cataract.
Thank you, sir.